I want to welcome everyone tonight. Thanks for joining us either in person or online. My name is Kevin Cruz. I'm the Executive Director with the Iowa Osteopathic Medical Association. And I want to thank Samin and Austin for their help in putting tonight's program together. So we are, as you could hear, recording the session. So I'll work with Austin to make the recording available online. So hopefully we can add it shortly to our website. The agenda, those first half hour, we'll have Sean Neal and David Kugash from the AOA. Second half hour is Sarah Allen and David Ailman, the IOMA lobbyists, talking about state issues. And then the last half hour is made up of IOMA board members and legislative committee members. So with that, Samin, I'll have you do the introduction.
Thank you. So I have the pleasure of introducing our AOA speakers. So first I'll be introducing David Kugash. He is the Senior Vice President for Public Policy at the American Osteopathic Association and leads the AOA's Public Policy and Advocacy Program, representing the interests of the nation's more than 150,000 osteopathic physicians and osteopathic medical students. This includes congressional and regulatory affairs, state government affairs, grassroots advocacy, and collaboration with external stakeholders. Prior to joining the AOA in November 2017, David was Vice President of Federal Relations for the American Cancer Society Cancer Action Network and led ACS-CANS efforts to increase federal funding for cancer research and prevention. Additionally, David served as chairman of One Voice Action Cancer, a coalition that advocates for increasing funding for federal cancer programs. And we also have Dr. Sean Neal. He is the Director of Grassroots and OPAC with the American Osteopathic Association and has more than 10 years of political and advocacy experience with a focus on fundraising, government relations, and grassroots initiatives. Sean currently heads the AOA's grassroots programs on both the state and federal, including DO Day on Capitol Hill. In addition to his role with the AOA, he also runs the Osteopathic Political Action Committee, the OPAC, where he serves as the point person for all political campaigns. Sean was one of the original founders and board members of the physician industry first super PAC, where he raised over $800,000 in less than 4 months. In addition, Sean developed a physician industry first charity PAC match which netted $30,000 for charity. He is the co-chair of both the Physician PAC Forum and Candidate Workshop, where physicians are trained how to run for Congress. In addition, he is the chair of Innovate to Motivate, a program that fulfills the professional development requirements to earn or maintain the Certified Association Executive Credential. So I will give it to now.
Well, thank you so much for that introduction and good evening, everyone. And thank you so much for allowing David and I to participate in this event today. I believe I know some of you, but again, just to quickly reintroduce myself, my name is Sean Neal and I'm the Senior Director of Osteopathic Political Action Committee and Grassroots for the AOA. And so today I'm going to cover a few topics that relate to our recent advocacy efforts, but I also really wanted to take a deeper dive into words and phrases that you hear all over TV, such as, debt ceiling, appropriations, continuing resolutions, and so on. I'll also take a moment to highlight some of our advocacy activities and how you can engage to help advance health policy that really benefits physicians, students, and patients. But before we get into all of that, I really just wanted to take a quick trip to civics and poli-sci 101. I know that a lot of this information is going to seem a little basic at the beginning, but we'll get more advanced as we go on throughout the presentation. So we have a lot of ground to cover today, so I'm going to try to get through this as quickly as possible. And that really just starts with how a bill becomes a law. And so first things first, the US Congress is made up of two chambers, the US Senate, which is made up of 100 elected members every 6 years on a rotating interval. And the US House, which is made up of 435 members, which is elected every 2 years to a federal position. So the total number of representatives each state receives is based on the population size that is reported by the US Census Bureau. So you are represented by 2 senators and 1 representative on the federal level for your state. And as for passing a law, it really is pretty much a straightforward process. You know, a lawmaker introduces a bill. If it approves, it goes to the other chamber. And if it passes, it goes into the president to sign the law. So this is a really simple, you know, straightforward way of looking at it. But there's many steps along the process that could really interrupt all this. And but this, in a perfect world, this is what it looks like. I also wanted to touch on the differences between legislation and regulation. And so an oversimplification of it would be that Congress writes and passes legislation to enact laws, and regulation attempts to monitor or regulate those laws. So the Department of Health and Human Services, or HHS, is the department that we engage with the most often when we are attempting to modify regulation, and of course Congress for legislation, excuse me. But the AOA is very active in both categories when attempting to pass common sense health policy. So I also thought it would be important to give a quick overview of the appropriation process, given, you know, you hear about it all the time on the news lately. So if you're a little unsure of the process, don't worry about it, you're not alone. But in a nutshell, this is what it looks like. And it starts with various agencies reviewing their own budget proposals and then submitting it to the Office of Management and Budget and the president to review. So in February, the president then in turn submits the budget to Congress. And, you know, this submitted budget is usually met with some skepticism or optimism, really kind of depending on who you talk to. Because the US House and the Senate, they also release their own budget plans and spending, and this is called a budget resolution. So this process of completing the budget resolution is completed by April 15th. So after the budget resolution is complete, appropriation subcommittees then review the budget to set funding for programs through appropriation bills. Congress then reconciles the difference between the House and Senate bills. They vote on a final package and then they send it off to the president, you know, who can either pass or veto it. There's also a chance of what we call an omnibus bill that can occur. So these are just unfinished appropriation bills that need to be taken care of by the end of the year, or those programs won't receive funding. So these omnibus bills are pretty important to us as the osteopathic profession in the AOA, because funding for the THC GME program, or the Teaching Health Center Graduate Medical Education Program, that we continue to advocate was included in last year's omnibus. So it definitely can be an important step in the process, but I know the process can be a little complicated, but just know that our department at the AOA of Public Policy, it really has a close eye on this process, and we'll make sure to notify the osteopathic profession when action is needed. So here is a quick look of important calendar deadlines of the process that I just covered. There's a lot of back and forth in Congress right now, and I won't get into a lot of detail here because David is going to cover much of this in just a moment. So when discussing the appropriations process, I also think it's pretty important to discuss continuing resolutions, which is an important tool for Congress to utilize to help keep the government funded. So to simply put, you know, continuing resolutions, or we call CRs, is stopgap legislation to prevent government shutdowns should Congress not pass a budget by October 1st. So here's just a quick chart that shows the frequency of CR since 1998. And really the only outlier here is in 2001 with 21 CRs. But overall, Congress has used this tool pretty consistently since 1998 and even before then. And so the duration of CRs also vary, and here are just a few highlights. The average number of CRs passed per year since 1998 is 5. The duration, the average duration of each CR is 39 days. In one fiscal year, the average total duration of CRs passed equates to 5 months. And finally, there have been 15 full year CRs enacted since 1977. But I really just wanted to provide a lot of historical context here, just because you hear it in the news so often today. Before I jump into methods on how and why we use advocacy and how to get involved, I'm going to go ahead and pass it over to David Pugash, who heads our public policy department, and he's going to talk through the issues about what we're working with and on and how they impact the osteopathic profession. So David, I'll go ahead and pass it over to you.
Thanks, Sean. And I want to thank student Dr. Khurshid for the introduction, and Kevin for putting this briefing together. I know I speak for Sean when I can say we were genuinely thrilled, by the opportunity to speak with all of you. If there's one thing I think that came through from Sean's overview so far is his passion, and I certainly share that, for advocacy and for really empowering others to engage in advocacy. And I think that's why, the primer that Sean just ran through is so important, because when you meet with lawmakers, when you meet with their staff, a lot of times they throw around terminology that can be confusing. And I think having just a general sense of the process and familiarity with some of the terminology hopefully makes the process seem a little more familiar, a little more accessible, because no matter what the issue is or what the ask, whether you're dealing with elected officials at the municipal level, in your state legislature, or in Congress, the way you accomplish anything is by addition, not by subtraction, through engagement and building common ground with people. And when you, are a little familiar with the process and comfortable engaging, and you're able to start to, build the relationship, it really does go a long way towards advancing your agenda and priorities. And that's really what our focus is, in our work. To put it just very succinctly at a high level, to do the most good for the most people. We want to help osteopathic medical students graduate and be able to pursue the careers, that they want to have. We want to help physicians practice in the specialty and practice setting of their choosing, and care for their patients in an optimal way. And so when we do that, and when we organize our work, we do that by identifying a series of federal issues that we want to focus on, and those issues are identified, at a high level with input from members of AOA, public policy bureaus, and councils. We do the same exercise you'll see in a moment with our state issues as well. So what you see on the screen, with our federal issues, this is by no means intended to be an exhaustive or comprehensive set of issues, but really at a high level intended to, provide an articulation for our members, for osteopathic specialty colleges and state associations and external stakeholders as well. Broadly speaking, what are the issues that we're focusing on? What are the issues in the upcoming year that we anticipate being most active on, notwithstanding any emerging area of need or opportunity? So when you look at support for physicians, what does that mean? Physician wellness is one of those issues, and in a few minutes you're going to see a piece of legislation that hopefully you're already somewhat familiar with, that we've been very engaged on this space. Workforce, that is in large part graduate medical education, funding, and authorizing legislation. Again, you're going to hear a little bit more about this in greater detail in just a minute. Access and affordability, that's preventing, for example, Medicare payment cuts, advocating for Medicaid payment parity, telehealth coverage, regulatory reform, pursuing flexibility on various reporting and compliance requirements for physicians, really reducing administrative burden. Public health and federal funding priorities. That's really where the annual funding that flows from the federal government to state agencies and non-governmental organizations through, for example, the Centers for Disease Control and Prevention, the Health Resources and Services Administration, and the National Institutes of Health, pandemic preparedness, emergency response, public health programming, so vaccine programs, tobacco cessation programs, research, other public health programs, chronic disease control, general public health prevention programs. That sort of falls into these buckets. And with regard to our state priorities, it's really not dissimilar when you look at those. So here you see similar categories or buckets of issues as well. Scope of practice, if that's not a term of art you're familiar with, that is when we address licensing issues and expanded or attempts to expand practice rights for non-physician clinicians, various allied health professions like advanced practice nurses, physician assistants, chiropractors, and a whole host of other, non-physician healthcare professions. There's telemedicine issues, there's liability issues, truth in advertising. That is a very important issue area. That's essentially state laws requiring that a healthcare professional make clear what their credentials are, so that you don't have somebody who's not a physician, but who holds themselves out, as a doctor in a way that can, have some ambiguity or confusion for patients. That's not to say that there aren't, individuals, be it, podiatrists, psychologists, who are entitled to use the term doctor, but to not conflate a doctorate with being having the training of a physician. Top middle osteopathic equivalency and recognition is obviously an ever important issue to ensure that DOs are included in policy, statute, regulation, alongside MDs and treated fairly and equally. And then, of course, you see the range of other issues there as well. So how do we put these issues into practice? And obviously, a lot of activities this year, but I think last year with the pandemic, there was just so much activity. It's worth highlighting what we were able to help, accomplish. And in no small part, as Sean mentioned, the grassroots engagement, the involvement, the direct involvement and advocacy of medical students and physicians played a significant role in this. So we were able to help secure the inclusion of significant funding for physicians, for nonprofits, for public health programs in the year-end COVID relief package last year that was tied to the annual appropriations omnibus. As Sean mentioned, that was the bundling of all the individual appropriations bills. We also were able to secure additional funding this year through the American Rescue Plan as well. But really at the end of 2020, a lot came together that was the culmination of essentially a year's worth of work that also included funding and expansion of graduate medical education programs. This included the reauthorization of the Teaching Health Center Graduate Medical Education Program and the National Health Service Corps. But it is so important to highlight, even though it's not a huge number, we also were able to help secure the first increase in Medicare GME funding in 25 years. And that represents 1,000 new residency slots that are being prioritized to support training programs in rural areas and also provide additional flexibility for training programs in rural areas. And so it's 200 slots per year for 5 years, and programs can start to apply for those new slots at the start of January, I believe. So that was last year. Here we are this year. A lot has changed since last year. And in the House of Representatives, Democrats are still in the majority, but their majority shrunk. In the Senate, the result of the 2020 election shifted control of the Senate to Democrats, but by the narrowest of margins. One thing I've seen in the news a lot lately is this is the longest 50-50 Senate that we've had in US history. And so what that means is that it's very hard to move legislation because as I think everybody is aware, unfortunately, we live in a polarized world right now. And so that means that the Democrats essentially need to have a united bloc to pass anything. And that's why you see a lot of red X's here and not a whole lot of green check marks. And this shows you all of the must pass items that are still left unresolved. One big item that's been in the news as of late is the debt ceiling. We have the annual budget resolution, which Sean referenced before, the annual spending bills, the appropriations process, which is actually separate from the budget resolution. And then you have other programs that are set to expire or have expired as well. With the debt ceiling, there was a deal that was reached in the Senate late last week. The House is expected to vote today or tomorrow, and assuming the House passes the extension that the Senate adopted at the end of last week, that essentially kicks the can down the road until technically early December, but that probably buys another month or so more than that if no deal can be reached in December. Congress passed a short-term funding extension, the continuing resolution that Sean mentioned, also through early December. So, conventional wisdom is they'll need another short-term continuing resolution to buy a little more time to complete their work on spending bills and see if they're going to combine that with the debt ceiling or not. The top program under the other programs category in your bottom right corner, the Surface Transportation Authorization, that is actually, even though not a program that the AOA obviously is directly engaged in advocating for, that's noteworthy because that actually ties into the ongoing debate around infrastructure. That expired at the end of the last fiscal year on September 30th. Congress gave it a 1-month extension through the end of October. And so presumably that's going to be one of the drivers that potentially pushes Congress to act on this social infrastructure plan that is currently in limbo. So the debt ceiling, it's worth noting, unfortunately, this has become a growing and increasingly partisan food fight over the last, I would say the last 10 years, but it also was an issue in the 90s at one point as well. But essentially, what you need to know is that rather than tying the debt limit to a dollar amount, because politically that's become fairly unpopular, and essentially this is the borrowing limit for the federal government, which essentially is tied to what we've already spent. The way Congress has handled this for the most part over the last 10 years is simply to suspend the borrowing limit until some future date. And then when it kicks in at that future date, it kicks in at whatever the total borrowing limit, however much money Congress has borrowed at that point. So the debt limit a couple of years ago was $22 trillion. And when it resumed on August 1st, it resumed at 28.5 trillion. And now Congress has to decide how it's going to move forward with presumably increasing it further or further suspending the debt limit come December. So some key dates this month and next month. As I mentioned, you have now an October 31st deadline on infrastructure that's tied to the transportation bill. The debt limit's been delayed until December. And, obviously everybody always has an eye towards the next election. So you have a few bellwether races coming up, a couple of gubernatorial races, and then a couple of special congressional elections in early November as well. The congressional races also do have a more immediate practical effect as they also, will potentially, either expand or further shrink the Democrats' majority in the House. So with regard to the big social infrastructure package, what you see in all the headlines is the price tag of this is $3.5 trillion. You have essentially some, progressive or liberal Democratic House members who want it to be at least that size or more. You have some more moderate or conservative members, the Democratic conference in both the House and Senate who'd like to see it, shrink a bit. And, right now it's unclear exactly where, they're going to reach common ground in terms of what the total, top line, spending level is. How much will it actually cost when all is said and done? And ultimately, what's going to be included in it? We know at a very high level within in the healthcare space, what do the Democrats want to do? They want to expand Medicare benefits to include dental, vision, hearing. They want to potentially lower the eligibility age for Medicare, although I don't think that's actively in consideration right now. They want to be able to expand Medicaid coverage for individuals in states that have yet to expand Medicaid. They want to make the Affordable Care Act tax credits permanent, or at least extend them. And they want to increase funding for graduate medical education as well. That's a big priority that we've seen for members of the House and Senate. So ultimately, how do we move forward? So we know right now that, there's an impasse. The $3.5 trillion price tag probably isn't going to be what it looks like if and when the Democrats reach consensus on this. Conventional wisdom is it's going to shrink. I don't expect anyone to strain their eyes and look at the fine print in the bubble, but essentially $2 trillion or a little bit more than $2 trillion is probably where they wind up. And what that means is, some things basically get, left out, other things will shrink. One thing that was included, at least in one of the committee markups, and I'm going to show a couple details on this in just a second, was a significant increase for the Teaching Health Center graduate medical education program. So in the House of Representatives, we've not seen a final package come together to go to the floor of the House for a vote. We won't until a deal has been reached, but the committees have done their work. And so two of the main committees of jurisdiction over healthcare, Energy and Commerce, Ways and Means. So Energy and Commerce, what did they do? They included $6 billion in new funding for Teaching Health Center graduate medical education. That would be a significant, I think actually sort of understates it, increase in funding for that GME program. Assuming some portion of it stays in, that would still be a win, but I think that $6 billion gets scaled back. They included a new Medicare dental, hearing, and vision benefit. Unclear exactly what that will look like when all is said and done. Energy and Commerce was not able to include any type of drug pricing legislation because they didn't have the votes to do it. The Ways and Means Committee, they also included the Medicare benefits. They included paid family and medical leave, and Ways and Means did have the votes to include drug pricing legislation. Both committees were able to take up drug pricing because they share jurisdiction over Medicare. So whether or not and what that looks like in the final package will remain to be seen. But it's also important to highlight a few issues that aren't eligible for inclusion under this reconciliation package. One thing that's worth noting, so reconciliation is a procedural mechanism that allows the Senate to circumvent a filibuster. It allows the Senate to pass legislation by a simple majority, but the rule allowing for this legislation to move forward without being subject to the filibuster limits what can be included in this legislation to anything impacting the deficit, either reducing or adding to it. It's taxing, it's spending, it's not authorizing. So any authorizing legislation can't be included. That includes some other of our priorities, such as telehealth legislation. One of those bills is the Connect for Healthcare Act. As the physicians on the call know, that under the public health emergency declarations at the federal level and in states, there's been an expansion of coverage and payment for a wider range of telehealth services. What this bill would do is make permanent a lot of the services that are only temporarily being covered and make permanent a number of the restriction, the changes and rules that removed some key restrictions to telehealth services. This bill, as you see by the numbers up top, has strong bipartisan support in the House and in the Senate. The Senate, you see there, it has a majority of the Senate, 30 Republicans, right, actually 27 Democrats co-sponsoring. In the House, similar strong majority. And so this legislation, I think, stands a pretty good shot of moving as part of a larger package later this year. But it's important that we continue, and we may need to do grassroots on this. Another important bill is the Resident Physician Shortage Reduction Act. You've heard me talk about the expansion of graduate medical education funding that we've seen Congress support. This legislation would create 14,000 new residency slots over a 7-year period, so 2,000 a year. It would be targeting health professional shortage areas. We've partnered with SOMA on this bill because of the size of this bill and the cost of it. It's definitely one that's going to need continued effort to move this thing forward, but there is a strong coalition of organizations supporting it. You have, as you see, bipartisan support here, Republicans and Democrats alike, because there is a recognition of the continued need, especially in underserved areas. So this is another one we'll be working on, really probably for the next year and a half until the end of the current Congress. Student loans, another big area for us. Really, whenever there's an opportunity to support loan forgiveness, we always pursue it. And this legislation, the Rural America Health Corps Act, would establish a new program under the National Health Service Corps that would expand, loan forgiveness opportunities for physicians who practice in underserved areas, and would in total forgive up to $200,000 of loans for 5 years of service, and waive any tax liability associated with a loan repayment program. While not a legislative issue, and hopefully won't need to be, it's worth noting that we're seeing, although the devil will be in the details, and it's unclear exactly how these changes are going to be implemented, but some much needed changes to the public service loan forgiveness program. That's a program that's already well established, but unfortunately not benefiting nearly enough people. And hopefully the necessary changes are being implemented there right now as well. So something to keep your eyes open for. Lastly, I mentioned physician wellness before. The Dr. Lorna Breen Healthcare Provider Protection Act. This legislation is named for an emergency physician who unfortunately died from suicide early in the pandemic. She was working in New York City and just really overwhelmed by her experiences in an ER department, in the early days of the pandemic. This legislation would authorize and establish new programs to provide grants to universities, medical schools, hospitals, other nonprofits, state and county health departments to support education awareness and direct services for healthcare professionals. What's interesting to note here, and really demonstrates, I think, Congress's recognition of the importance of this issue and the severity of the need, is that in the American Rescue Plan, which was signed into law in April, they included $140 million for this program of work for these services. As I mentioned, the reconciliation procedural mechanism allows the Senate to move legislation with a simple majority, but it doesn't allow for the inclusion of authorizing legislation. So the American Rescue Plan was passed, that legislation moved through the Senate using this reconciliation mechanism. So then the Senate was able to include the funding, but not the authorizing language. So while having the funding is probably in other circumstances harder to come by than the authorization, we still absolutely need to see this legislation enacted into law, because the programs need to be authorized and HRSA, the Health Resources and Services Administration, really does need to be directed as to how these programs should be structured and how this money should be spent. Very important progress there. And with that, Sean, I'm going to hand things back to you.
Thank you, David. I know we're running just a little bit behind here, so I'm going to try to zoom through these slides as quickly as we can. But before we do, I really just think it's important to define advocacy, which really in theory is pretty straightforward. So advocacy is a citizen or group of citizens attempting to influence lawmakers. So you can engage in advocacy in many ways, such as showing support or opposition for legislation, asking for change, telling stories, sharing ideas. There's many different ways to providing information to your representatives. So in turn, lawmakers will create these laws and regulations based on the feedback that they hear from their constituents. And really, that's why it's so critical to stay engaged. So there are different levels of engagement, but keep in mind that Congress really does move at a slow pace. So it can take multiple years to pass a bill. So when you advocate, just remember to be patient and be resilient. The most important thing to keep in mind is that your members of Congress, they really do want to hear from you. We know that policy can move at a pretty slow pace, but how can we get a particular bill across the finish line? So there are different ways to advocate, but not all strategies are created equal. So a recent study polled Capitol Hill staffers and asked them a really simple question. If your boss has not already arrived at a firm decision on an issue, how much influence might the following advocacy strategy be directed to the Washington office have on his or her decision? So as you can see, an in-person visit from a constituent is right there at the top. So 46% of Capitol Hill staffers said it had a lot of influence on their boss's decision. So compare this to only 19% from sending individualized emails. Now, I will say that all these forms of engagement are important and they do play a critical role in the process, but just some, have higher priorities and can be a little bit better than others. So members of Congress, they really do value from staying in touch with their constituents. And so, as physicians and students, you really are the subject matter experts on a lot of healthcare related issues. So the conversations that you'll have with them in the future really helps them create policy. So while you're engaged in advocacy, it's also really important to know that very few bills actually go on to become a law. A small percentage of votes in Congress, will go on to get votes, and even a smaller percent will go on to become law. So as I mentioned, we really need to be resilient in the legislative process, as well as set realistic expectations. So, even though a particular bill does not pass, it can still have important implications. So very few bills do go on to become law, but even bills that are unlikely to pass still can cause, a media frenzy or be powerful political tools. So in the 116th Congress, more than 14,000 bills were introduced, and only 5 to 6% made it to the House or Senate floor. And so even a lesser percent went on to become law. So really, it is a huge accomplishment to pass a law. And I know this is something that the AOA and our osteopathic affiliates and students, they really work hard to do this each cycle. And so one of the many reasons why our Department of Public Policy exists within the AOA is to pass this pro-physician and student legislation. And that can't be done without momentum and just the constant beat of the drum on Capitol Hills on these issues that directly impact you. When we start a grassroots campaign, it doesn't end with an email. It is consistent and sustained engagement throughout the year. Some of that engagement is done through direct lobbying in our department, but others really comes from engagement from our members. And so I know everybody has heard the quote, 90% of success is just showing up. And I really think that picture kind of illustrates this quite nicely. So this is an actual town hall with a member of Congress. And, what do we see from this picture? 6, 7 people here. So, imagine if we can have the impact that we can have if we just fill this, this room with osteopathic physicians and students in those seats, once the pandemic restrictions starting to light up. And so that is exactly why we created the Osteopathic Advocacy Network, really to help build a better relationship with lawmakers in order to pass legislation that really not only benefits physicians, but the patients they serve as well. This is a network created by the AOA that brings osteopathic physicians and students together that want to engage in advocacy at a higher level. We also understand that our members are extremely busy. So we've developed 3 tiers for them to sign up. So we have an introductory level, which is called an advocate. The second level is called partner. And the third level is what we call ambassador. And, I'm not going to walk through all the requirements there, but you can see them on the screen. We also host monthly public policy roundtables for our OAN members. These are just informal Zoom meetings where we discuss health policy and what to expect from Congress, really not too different from what we're doing right now. So David covered some of the background on the bills that we're working on. So I really am not going to get into the details of these bills, but I did want to touch on some of the methods and grassroots tactics. And this is one example. So using our advocacy software, we're able to generate thousands of letters to Congress from constituents that encourage them to take action on a particular bill each year. In this example, we partnered with SOMA, encouraging osteopathic students to send their lawmakers an email or asking them to support, the Rural America Health Corps Act. And from this single alert alone, we generated just under 1,000 letters to Capitol Hill. So these emails, they're pre-written. So all you have to do is hit submit, and it automatically sends an email to your federal lawmakers. They're all editable, and we also encourage you to personalize it as well. So staffers on Capitol Hill in turn will go through these emails and inform their boss just how many individuals in particular wrote on a topic. So keeping the momentum on bills like this by sending letters of action really is pretty critical to help building momentum. I also quickly wanted to highlight that although we are busy working on federal and grassroots legislative initiatives, we haven't let up assisting some of our state affiliates on their initiatives as well. Our workload for state affiliates, it does really ebb and flow throughout the calendar year because each state legislative body meets at a different time. So as you can see from this map, most states are actually out of session this far into the year, but there are a handful that still are in session. And so what you see in front of you now are just a couple of examples of some recent grassroots efforts that we partnered with our affiliates on. And from these 2 alerts, we partnered with SOMA and the Louisiana Osteopathic Medical Association, respectively, on 2 completely different issues. So one, accepting access to vaccines for medical students. This was early on in the pandemic. And 2, protecting patient safety by stopping practice authority expansion legislation for APRNs. So the interesting thing about these 2 campaigns is that they target 2 completely different entities. So for the vaccine alert, we directed our letter to each governor in each state. And for the practice authority expansion campaign, we targeted lawmakers on the state level. So, your state senators and your state representatives as well. So in addition to our letter writing campaigns, we also launched social media campaigns that target the lawmakers' social media handle. So this is really a more aggressive strategy, just given how public social media is. And again, all these are editable, and we always encourage individuals to personalize to help get your message stand out. But as we saw earlier, there really is different levels of engagement and that have the different levels of influence on Congress. And right at the top is that face-to-face interaction. So in August, we created an advocacy action alert that allowed our OAN Osteopathic Advocacy Network members to reach out to their representative's office directly to schedule a meeting. It really was kind of a straightforward process, so similar to our typical grassroots alert. With one click of a button in this campaign, an email can be sent directly to the office under your name, just asking to schedule a meeting with the representative or their staff. For the individuals that were able to schedule a meeting, much like DOD on Capitol Hill, we provided them with training documents, issue fact sheets, talking points to help prepare the advocates in their meeting. And I should also mention, when we did have these meetings, I think I think it was probably nearly 100% of the offices that we met with ended up co-sponsoring on the bills. So it really is critical to meet with these lawmakers face to face. And when I say face to face, Zoom is just fine as well. And I would be remiss if I didn't briefly mention our Osteopathic Political Action Committee, or OPAC. So this is our committee that supports our political operations by helping to elect and re-elect pro-physician and medical student candidates to Congress. So we're a bipartisan PAC, so it really doesn't matter if the candidate is a Republican or a Democrat or an independent. What really matters is where they fall on the issues. So we are 100% funded by our members and are led by a board comprised of 10 osteopathic physicians, residents, and students. So if you would like to support our political efforts, I encourage you to do so. You can do so by texting OPAC to 41444. And so our advocacy efforts, if this sounds interesting and this is something that you want to be more involved with, I encourage you to sign up for the Osteopathic Advocacy Network at osteopathic.org/grassroots. This is completely free to join. We also have OMED right around the corner. So if you haven't registered for that, you can do so at omed.osteopathic.org. This is also free to register for our students. And I know, they have some great content presentations for students lined up. And before I hand it back over to David for some closing remarks, I just, again, want to thank everybody for having us tonight. It really is just a pleasure to be in front of our members. And so hopefully with the pandemic behind us soon, we'll be able to meet in person. Okay, and with that, I'll go ahead and turn it back to David.
Thanks, Sean. And I want to thank all of you again for your time tonight and for the opportunity to join you. Just to echo Sean's comments, I really can't overstate enough the importance of your personal engagement and advocacy, whether it's sending emails to your lawmakers when you see an action alert, or getting to meet them and get acquainted with them and their staff and building relationships over time. You will be well served by that outreach. You are your own best advocate, and whatever we can do to support and facilitate that advocacy, it's our pleasure. So please feel free to call on us at any time with any questions, or if we can be a resource in any way. So with that, student Dr. Khurshid, let us turn it back to you.
Any questions for Sean or Dave? Thanks again for joining us this evening.
All right. And I will be introducing our next speakers. So the Iowa Osteopathic Medical Association contracts with Cornerstone Government Affairs to provide lobbying and regulatory services to the association. Two principals at Cornerstone that work with IOMA are David Edelman and Sarah Allen. David Edelman joined Cornerstone Government Affairs in 2010, bringing over 10 years of substantial experience in grassroots advocacy, developing and implementing strategic legislative campaigns, drafting and analyzing legislative language and reports, and establishing, administering, and advising political action committees. Before joining Cornerstone, David worked for a law firm in West Des Moines, where his practice focused on government relations, legislative law, PAC compliance, and strategic advising and election law. David drafted, assisted in the language, and secured funding, establishing a full medical school loan payment or repayment program for primary care physicians. Next, Sarah Allen joined the Cornerstone Government Affairs in September 2016. She brings over 5 years of healthcare experience, as well as years spent lobbying, developing, and executing policy positions, engaging grassroots advocates, and assisting with political action committee campaigns and endorsements. Sarah assists clients throughout the legislative and rulemaking process, focusing on healthcare and state government concerns. Prior to joining Cornerstone, Sarah worked as a state lobbyist and staff attorney for the Iowa Hospital Association. In this position, Sarah gained expertise in a variety of areas impacting hospitals and other healthcare providers. These areas include financing and reimbursement, behavioral health, value-based healthcare, delivery reform models, informational technology innovation, regulatory and legal compliance, scope of practice concerns for specific providers, public body concerns, and public health initiatives. So with that in mind, I'd like to turn it over to our panel.
Thank you. It's nice to be here tonight in person. Thanks for the clap. Get a little lively here. Well, we're happy to be with you. We were just saying before we came in today, it's nice to be back in person. And I'm assuming a lot of you guys are in training to become physicians, so kudos to you. What a time to entertain the idea of becoming a physician, so kudos to all of you. I'm Sarah Allen. I'm a lobbyist for a firm called Cornerstone Government Affairs. I focus a lot on our healthcare practice. And sorry, I have not done public speaking with a mask on, so you go, David.
All right, perfect. So are you guys second years or second years? Okay.
Yeah.
So all second years? Excellent, very good. So my name is David Edelman. I am Principal Director at Cornerstone Government Affairs. As my bio said, I've been with Cornerstone now for 11 years. The majority of the clients that we represent are healthcare focused, but we have about 45 clients ranging anywhere from the DOs to the family physicians to Unity Point Health, the Iowa Healthcare Association, which is the nursing homes and intellectual disability organization. And then on the other side, we represent municipalities, we represent casinos, banks, insurance companies, so kind of really the full gamut. Our firm is overtly partisan. So many people say that, you know, we should be a nonpartisan. Well, unfortunately, politics has become extremely partisan. And so we try to make sure that no matter who wins an election, our clients are always winning. And so we have Democrats as well as Republicans. Our Democrats, the reason I was late, I was just hosting an event for Tom Miller, who's the Democratic Attorney General, and I had worked for a Democratic state senator and worked on a presidential campaign. We have Republicans that have been chiefs of staff to Governor Branstad, the legislative director for Tom Latham, who is a former Republican congressman, as well as Governor Reynolds. And so the idea is that if you are nonpartisan in your lobbying efforts, you're basically just an information gatherer, which could be completely beneficial for your clients because just navigating politics is difficult. Maybe not as difficult as practicing medicine, but it's something that is not necessarily common or you growing up to say, I want to be a lobbyist when I grow up. And so the fact is probably close to, if not more, 60% of how you are going to get paid is government through Medicare or Medicaid. And so you need an advocate on your behalf because these legislators in the Iowa legislature, being 150 of them, there's not a single physician. I think there's now just one.
One nurse, two dentists, and then the nurse is actually a physician's wife. So she brings a lot of background, just having that medical background.
But the rest of these people really don't have any medical sense, and they're dictating how, frankly, you all practice. They're dictating on how you get paid. They're dictating how who practices what and how medical services are provided, whether they're provided by a physician assistant, a nurse practitioner, a pharmacist, a podiatrist, a Boy Scout with a sharp pocket knife, any of those different things. So again, you all are practicing every day, obviously saving people's lives, treating people, being proactive in your medical delivery. we are responding to reactions and reactive issues up at the legislature, as are the others that we're talking about, members of Congress. So our firm, Sarah and I, we're actually with a national firm. So we have 65 individuals in Washington, D.C., representing national interests, and we have 11 state offices. So in total, we have about 125 colleagues of ours in different state offices. What's interesting, and I know I'm jumping around, but we'll focus back into the state legislative piece. What's interesting, in my bio, we talked about how, I guess it was 6 years ago, I wrote the Iowa Rural Loan Repayment Program. What's interesting about that model was then taken into the other states that we have colleagues in, and they didn't have to recreate the wheel. They just put it on the plate. Legislators said, well, does it work? And they said, yes. In Iowa, there are now 12 students every year getting a full loan repayment program. They practice in rural Iowa. And they said, great, if it works in Iowa, it's going to work in Mississippi or Georgia or Louisiana or Texas or Annapolis or in Maryland, whatever the case may be. So that program creates a full loan repayment program if the student goes to DMU or University of Iowa, does a residency program in family medicine, general surgery, internal medicine, psychiatry, OB, and OB. And then go and practice for 5 years in a town of 26,000 or less. If you meet all those criteria, you get your loan fully repaid. Someone says, gosh, why all the hoops? Well, based on studies that we've seen, if you go through all those hoops, 88% of those physicians stay in that area. So the idea is, if we're using taxpayer dollars, you're creating an economic engine. Each of you, whether you're practicing medicine, but you're also an economic engine. You as I don't know where you all are going in or what type of specialty you're practicing in, but a family doc in rural Iowa generates $934,000 of economic impact every year. They also employ 7 jobs in and around themselves. So Come and Go and Casey's and Farm Bureau all gave money to this program because they're rural Iowa, right? They want to see that success. So again, the benefit of having a larger firm is the resources that we have in Washington, D.C., and then being able to utilize each other for like best practices and things like that. So I'll turn it over to Sarah to talk a little bit about kind of the state of play here in Iowa and what we've seen kind of just recently and what we have to look forward to in 2022. And then we can jump in for conversations as opposed to a lecture.
Sure. Well, this year is a non-election year, but it is an interesting year in that we're going through a redistricting process. And that is based on federal census data that we received late this year. So that's kind of created a bunch of issues for states and how they do their redistricting, which is essentially a redrawing of congressional districts and then the state Senate and state House of Representatives seats. So it's a really big deal. It impacts a lot of people. Just to give you a little bit of the lay of the land here in Iowa, we are under a Republican trifecta control. So they control the governor's office, the House, and the Senate, and really have large majorities in both the House and the Senate. So things that they've been wanting to do for years as a party, they've been able to get done. One we'll talk about later has failed, and we'll talk about why it's failed. But with that, that just kind of gives you a little bit of the political backdrop as we talk about redistricting. Redistricting happens every 10 years in states. And again, it's based on the federal census data that you fill out, turn into the federal government. In Iowa, we've always been looked to by other states as kind of the example of how you want to do redistricting. What we do is we have our nonpartisan legislative services agency create a map, and the map is supposed to meet several guidelines or factors that are laid out in our Iowa code or our law. So then they submit that to the legislature, public comments 3 different times. It's usually today, 3 days in a row. And then it goes to the legislature to vote on it. This first map that came out to give a little facts, because I think it's fascinating, 45 legislators were thrown in together. So a third of the legislature, with how the maps were redrawn, were basically drawn in together, leaving 45 vacancies. That's huge. It's almost a third of our legislature. The Senate, who voted to reject the map, so the House didn't even have to come in and actually vote on it, voted it down due to compactness, and this might be really boring to all you. It's kind of fascinating to me. But our code talks about compactness and how the shapes of the districts should be rectangular, hexagonal, or square. And what a great state senator to listen to on the floor described one of the districts as a salamander shape, which it really did kind of look like it. And he went into this history about how in the 1800s, the same thing happened somewhere. And that's how we came up with the term gerrymandering. So if you want to Google a story about that, you guys know what I'm talking about?
I think it was Massachusetts.
Okay, okay, yeah. So anyways, it's kind of fascinating. So what they're saying to our nonpartisan agency is, hey, these are our concerns. We want you to address them. We think we're in line with Iowa code. So I wrote these down because I can't remember dates anymore. So the 21st of this month, we'll see our second set of maps. So if you guys, you should put it on your calendar. You can go look for the salamanders. But we'll see these maps, and then there will be 3 public comment periods. And then on the 28th, they're going to have another special session. So all 150 of them come in and either vote up or down on it. The hope, and I as a Republican hope that they just vote for it, because then it takes the politics out of the process, right? If they go to a third map, they're able to amend it. And that's when a lot of accusations go around about your gerrymandering, your drawing districts to, help you win elections. And just literally being the light on the hill on how redistricting happens. I honestly think it would be, David gave me these words, it's an unforced error, I think, for Republicans to do that, barring the maps being absolutely terrible and not complying with Iowa code. So that's where we are right now. Our state is really healthy economically too, which is good news. If you guys want to settle here in Iowa, we're looking at doing large scale tax reform. Republicans are in the next session. We want to be competitive with states surrounding us. This is just an example of how much money the state has. We ended our fiscal year with $1.1 billion in an ending fund balance, which lots of fiscal hawks look at that as almost budget mismanagement. You want to spend every dollar in your budget, right? I don't know if anybody's ever listened to Dave Ramsey, but you want to stick to your budget, blah, blah, blah. So we will see, based on that and just kind of how much money we have in our coffers, Republicans are really going to look to how do we do tax reform to benefit every Iowan.
Yeah, I would say, all joking, or I guess putting the jokes out there, for the Republicans to have a $1.2 billion ending balance is frankly mismanagement. And if you were a fiscal hawk, you would want to primary every Republican because the fact that you would leave it out there. That being said, there is all that money out there, including all the ARPA money, so the state, the American Rescue Plan money. So the state received $1.4 billion from the federal government right after Biden was elected to deal with COVID response. In addition to that, as the gentleman spoke up prior, you've got the infrastructure package that could potentially move, as well as the budget reconciliation package that could move. So there's going to be a ton of money flowing into the state. So how do you best deal with it? So this is where kind of priorities lie. What do you do with those? What do you do with those dollars? Do you put those dollars into safety net programs? Do you put those dollars into tax refunds? Do you put those dollars into additional workforce programs? And that's one of the big issues that the governor is talking about. And frankly, this is not an Iowa problem. This is a national problem right now. It's just with workforce. I think you probably, if any of you are going to a coffee shop or a bar or a restaurant, you're seeing help wanted signs. If you are listening to the news today, 2,000 Southwest flights were canceled. They blamed it on air traffic control. FAA said absolutely not. This is you guys just not having staff and people. And so whatever the reason may be, workforce is a huge issue. In Iowa, based on going back to Sarah's point, based on those census numbers, Iowa didn't grow. I mean, we grew 200,000 people, I think, in 10 years, which is one of the slowest growing states. And so the issue is, if you want to be competitive and if you want businesses to be here, you need people. And so how do you get people? We don't have oceans, we don't have mountains. And so we need a high quality of life, we need good education, and those types of issues. So I think that's really where the Republicans and the governor are going to try to put their resources and their efforts this year. As Sarah said, in a massive tax reform piece of legislation and then workforce legislation. I think the unicorn is, what does workforce legislation look like? I mean, you could do this for physicians, obviously dealing with your loans, but how do you bring other people to the state? Like, how do you legislate that, especially with Republicans wanting to be out of people's personal spaces? How do you insert government in to help with workforce? But I think that's also another issue kind of with kind of the current state or the competing interests within kind of the Republican Party right now. You can have the populist message, which is more kind of governed by kind of the former President Trump, and you have the establishment Republicans, which is strong national defense, limited government, tax reform, whereas the more populists are saying, well, we're going to insert ourselves into schools and say you can't have masks, or we're going to insert ourselves into vaccine mandates, things of that nature. So right now, with 18 Democrats versus 32 Republicans in the Senate, 40 Democrats, 16 Republicans in the House, you really no longer have a Democratic voice in the legislature. So right now, the competing voice or the opposition voice is kind of the old school Republican versus the new school Republican, and frankly, the Democrats are on the sidelines right now. And
something interesting when you're looking at everything we're talking about is, how do you really attract workforce? And I think the Republicans would argue we need good tax reform, we need all these good policies, because to David's point, we don't have mountains, we don't have oceans, our winters kind of suck. It's pretty flat around here. Why are people going to be here? And this has been something since your time.
Yeah.
I mean, this is why the rural laundry. Yeah, he's really. Right, he's really not. Yeah. But that's why the rural laundry payment program was bred. I mean, there's so many different programs. If you went and looked at the Iowa Economic Development Authority or the Workforce Development Authority in our state, that are geared towards getting people here. So I think you will just see a massive amount of conversation if you tune in at all into Iowa news and what's happening here. Because to David's point, you can go anywhere in the state right now. Everything takes 10 times longer to get, and it's really because of workforce. But I would say all of these things go hand in hand, and that's a cool part about our job, is you kind of start to see why people, like, why am I into tax reform? What's the purpose behind that? Why am I into, growing jobs or upskilling workers? That's a program that the governor has had for the last 3 years. And it's really targeted to, we need jobs here, but we also need employers here, right? Because without employers, you don't have jobs, and without workers, you don't have employers. So it's kind of a cool way to look macroly at the state.
So I think jumping into issues that you guys are going to be focused on, like, so scope of practice issues are always around. So you always have naturopaths claiming that they can cure cancer, and so they should be licensed in the state of Iowa. You always have direct entry midwives, not nurse midwives, but you have direct entry midwives saying, the family docs don't need to be the only ones that are delivering babies or OBs. We can provide that service, as a lay midwife, I can provide that service in rural Iowa, and I should be able to get paid for it. You have pharmacists claiming that they can, do kind of the whole range of vaccinations and immunizations. And our job on behalf of Bioma, specifically the pharmacist, would say, you may be able to do that. Obviously, pharmacists have been great advocates on the COVID vaccine rollout. However, it is still important for these young children to have a medical home. And using the vaccine as a hook to get them into the physician's office so they can develop that relationship with the physician. So they can talk to the physician about other areas of interest and talk about kind of the proactive component of it as opposed to the reactive piece. Their argument on the other side would be, you have a single mom of 5 kids who works. The only time that she has to get them into a medical setting is when she's shopping at Hy-Vee. So why wouldn't we be able to do that? So that it is a hard argument for us to justify. And frankly, because the pandemic has made it worse. Because now you've had a COVID vaccine that up until recently was only emergency use authorized, being administered in a parking lot. And frankly, there hasn't been, there's been obviously the random, bad outcome, but for the most part, it's been an overall success. So the argument would be, well, why can't I do that for influenza? Why can't I do that for Tdap? Why can't I do that for Gardasil, for the HPV vaccine? So these are the issues that we are fighting. And it looks like we are creating these turf battles. More easily, it is better for us to talk about naturopaths, basically saying there is no benefit for a naturopath to be licensed in the state or a lay midwife catching babies, because the outcomes are so much more drastic. So those are issues that we fight. Around the country, nurse practitioners don't have independent practice. In Iowa, physicians lost that battle in the 80s. I was not around in the 80s. But physicians' assistants are now wanting to do the same. They say, well, our training is just the same as a nurse practitioner. Why should we have to be under supervision of a physician, even though their name is physician assistants? So now around the country, they are trying to change their name to physician associates as opposed to physician assistants to use that leverage. So those are issues that we are working on your behalf to fight, not because you guys are getting paid more, but because it is in the interest of the interest of the patient and the quality of healthcare that we are providing. The joking around piece of kind of a Boy Scout with a sharp pocket knife may be, the person in rural Iowa, but that doesn't mean that he's providing or she is providing good healthcare coverage. So those are some of the issues that we're fighting on scope of practice. Another one is medical malpractice. So in Iowa, our your insurance premiums are skyrocketing because of non-economic damages that in jury awards. So a jury is awarding a plaintiff $80 million against a physician for pain and suffering, or something along those lines. We are losing residency programs. We're losing physicians in rural Iowa because, frankly, they can't afford to practice. So we are trying to put caps on non-economic damages, not on economic damages, but non-economic damages. And frankly, it's an extremely difficult, it's extremely raw and emotional fight that we believe is in the best interest of Iowans. To Sarah's point, in workforce for physicians staying in Iowa and continuing to practice in Iowa. I mean, a state that we never try to compare ourselves to is Illinois. Even Illinois has caps on non-economic damages. And so that's another issue that we will be fighting for on your behalf next legislative session.
Right. Yep. And that's an interesting issue. Residency programs, which all of you guys would really care about, is that's going to be the next step of your education, are not being able to afford these spots. And I think just last year, Cedar Falls or Waverly shut down a residency program. So it's huge. And then that just fuels the whole issue about we're not training as many physicians as we were before. And studies and statistics show where people do residencies matter. They tend to stay there. They put down roots. They maybe got married, had a kid or two during that part of their life. So it is a really big deal. I will just say, I think part of the aches with Republicans, because this is a party platform issue.
Can you guys introduce the name? Because I think that this might be the first time that some people are hearing about this.
Tort reform?
Yeah. I think
Yeah.
people might not be
Yes,
So toward,
like, so it's,
I am, but
yes, so
Thank you.
malpractice, basically here in our state, we've always really had pretty good case, dollar verdicts from juries. Well, over the last 4 or 5 years, we've just seen exponential awards given from juries in malpractice situations. You know, it's anywhere from a bad, child delivery outcome to, you know, surgical errors, whatever. There's a lot of cases out there that you can point to. But the point is, in law, common law, legalese, once you start getting these verdicts and these amounts, it becomes more and more normal, right? Because if I'm serving on a jury the next year, well, I know a council loss jury gave somebody 80 million bucks for their pain and suffering. And when we talk about non-economic damages, those are different than your economic damages. So economic damages are tangible, they're quantifiable, they're things like, I'm not going to be able to be a lobbyist anymore. So you need to take that into consideration for the next 30 years I would have been working, or whatever it is. You can put it into an algorithm that spits out a number. But the non-economic damages, pain and suffering, loss of consortium, how do you put a dollar amount on that? And that's where you get these large scale jury verdicts. So this has been something we've worked on for 2 or 3 years. And frankly, when the House had a great election cycle in 2018, I mean, everybody thought this was going to be a slam dunk. We had, you know, an 8-seat majority.
he says great election results.
Right. Right. You know, you could lose 7 votes, which that's a big number for Republicans, because this would normally be a party platform issue, tort reform, you know, having physicians have a good environment to practice in. Is that what you were asking for, more detail on that?
Yeah.
Yeah.
I really appreciate it.
Yeah, and this is something too, you know, as you guys, because where you end up practicing, you will become people that legislators look to, or community members look to for your opinion on stuff like this. So it's really great that you are engaged in an association, because you can kind of meet people like David and I, you know, who can tell you in real time what's happening at the Capitol. And so, you know, lend your voice on whatever issues you want to and that you're passionate about.
So it's 7:45, I think we're supposed to probably stop at 7:30, is that? So should we, you want any questions, or are you
Yeah.
going?
Are there any
Questions?
I just have a comment. I came out of a training program here out in DO 25 years ago. And I don't think it was a program sponsored by the state. I actually think it was a program that ran through the school. I practiced emergency medicine in Clinton, Iowa, and got a big chunk of my loans forgiven for each year served. That's the way you did it back then.
Yep.
So I benefited from that. So there's programs. I mean, you guys are gonna come out with a number that you're gonna gasp every time you look at it. I'm sure they keep track of it for you. The estimates on the interest repayments and all that. But every state, and we're very good at it, you just described our program, has programs that will help you pay back your loans if you'll serve in an underserved area. So don't let the number fool you. And here's my only other piece of advice. Every contract you get, knock on one of these guys' door. I was talking about the gentleman who's get a lawyer to do your time. No matter how smart your mother or father is, they may be DOs, MPs, XYZ, get a lawyer to do your time. And a lawyer that's done it before.
Well, and frankly, a lawyer's gonna do before you even sign it, negotiate it, right? So negotiate, a lot of your employers will probably ask them to take a third or a quarter of your student loan debt off your plate too, as part of your compensation package. I mean, all of that is worthwhile. Because look, now everybody, especially in Iowa, they want you guys more than, not that you don't want them, but they want you more than you want them. And they will do anything. I mean, they're gonna bend over backwards to get here. So,
And don't be afraid to ask for the big number.
yeah.
You don't know the kind of value your degree holds. You don't know, you don't realize. So don't be intimidated by asking for big numbers. have a lawyer help you with those. That's,
And listen to that lawyer and do what she says. I'll tell you a story about it. The whole program born at the University of Iowa, because it was what a lawyer says, and that lawyer is related to somebody who went on faculty in our school. Boy, that was a couple weeks ago. 30, 40 years ago. Listened to a lawyer, said, don't make this one change in contract. Wouldn't make it. He said, you're busted. Listen to your lawyer. It's worth every time you go.
Any other questions? Yes.
How do you anticipate the redistricting will affect court reform?
Yeah,
This year it won't impact it from 22, because you'll have the same legislature.
maybe a little bit because of the West residency.
Oh, that was an odd.
So there's a special election happening in Newton. There's a Democrat that resigned his seat because he took a job. Doesn't have capacity to run. That will flip. That'll become a Republican seat. Maybe it's becoming red. So instead of having 41 Democrats and 59 Republicans, you'll end up being 40 Democrats and 60 Republicans. So then therefore, like if that Republican gets a yes vote, then that adds another number on the court reform yes column or less yes side of the ledger. So you go from there.
So Dave or Sarah, how close have votes been? Is it a House issue or a Senate issue?
It's not a Senate issue at all. The Senate's very conservative. Senate Republicans call the House Republicans rhinos, Republican in name only.
I just learned this today. Somebody said it and I had to Google, what is that?
I think the House leadership has a different style of leadership than the Senate leadership. The Senate leadership is very strong. They're very unit. The House is a little bit more fractured. Granted, there's 50 members in the Senate, 100 members of the House. So the Republicans have 32 in the Senate versus 60 in the House. So it's more frogs in a wheelbarrow, trying to keep them inside. We believe we are right around 48, 49 yes votes last year. We need 51 to pass it. We also believe that if the Speaker of the House decides to twist arms or call whip votes, then if they're whipping those votes, we believe we can get to 51. It's extremely hard, but it's something that we believe is a priority. The governor supports it as well. So we'll go from there. That's the other thing, as we talk about who are Democrats, who are Republicans, both Sarah and I are attorneys, and as attorneys, you represent your client's interests, not your own interests. We as lobbyists represent our client's interests, not our own interests. That being said, my father happens to be an alumni of Des Moines University, and so as a Democrat, I do also support tort reform though too. So it makes it a little bit easier.
Right. And you always drink the Kool-Aid of your client too. That's why we're picky about who we work with, because if you don't
You have to
agree,
believe, yeah.
if you don't agree with what you're arguing for, that would be problematic, so.
You're not effective.
So just out of curiosity, because I'm a nerd and I'm avoiding bedtime for 5 minutes. I have 4 kids, so if I am not home, I don't have to go. But what are you thinking for your specialty? Where do you want to end up? Or do you know yet?
I'm thinking internal medicine. I'm from Iowa. I'm also getting my MPH here at DMU, so I'm kind of hoping I can do part-time clinic and part-time, work with the health department or do something in policy.
Cool.
Also thinking internal med, maybe rheumatology, not quite sure, kind of far away from that, but yeah, open to a lot of internal med, that sort of thing. I'm from Iowa too, and I'm on the Iowa Medical Society board, so I'm very in the know about tort reform right now, but I want to do share because you're better speakers than I
Not at
am. So thank you.
Yeah.
I'm a first year, so I'm not sure yet. Cool. Cool. I'm interested in family practice and maybe OBGYN.
Cool. Awesome. I still haven't really have like a set idea, but probably some form of like internal med. Cool.
Yeah, I'm also pretty unsure. I have a lot of interest, kind of leaning towards something surgery related, maybe OBGYN. And my family's from Chicago, so I'm hoping for residency to go back there.
Oh, man.
Gotta twist your arm to stay.
And I'm thinking either emergency medicine or surgery, but I'm from Mud Cities originally. Specifically.
Cool.
Yeah, I'm thinking about surgery.
Awesome.
I think with the kind of last 5 minutes we have, want to maybe call on some of our board members or legislative members if they could share. If they've had a personal interaction with the legislator, or if they have any kind of words of advice for students for getting involved in the legislative process. So, I don't know. Questions on any thoughts?
Talk to your legislators. Exactly what you heard here tonight. Went to your office, talk to them, talk to their staffers. Staff has got a tremendous amount of influence. That's kind of like the word about the doctor, being friends with the doctor's nurse, then you're in. So these staffers will help you tremendously become a resource person, become someone they can call. I've worked with our federal, both House of Representatives and Senate side, and got to know the representatives, the legislators very well by working with their staffers. If you get a chance to go through your professional society to professional training on leadership and advocacy, please do that. College of Emergency Physicians holds one every year, and they are tremendous opportunities. They will put you up at a podium, video you, and someone there will prepare you for it, put you back together in high school. It's a wonderful experience. No, humility.
Yeah, and I know Sean had talked about he runs a program, similar program for the AOA. So.
Oh, boy. Yeah, and just, again, like I said, don't be afraid to reach out to your representatives and legislators. And if you have a question, you know, and as Dr. said, I hear that their staff can really help you and be helpful. So don't be intimidated. I mean, you're the future leaders. And go up kind of sectioning back to everybody that's in the room. My son's in the third year in this program, and he was going through the same thing. What am I going to do? What am I gonna do? Well, first of all, figure out what you don't want. Okay, cross those off your lips, and then add. Then you comply with this, and then before you know it, you'll be looking around and be a good physician, and you'll be doing what you like to do in this. So then you never go to work. Just practice medicine.
One of the points that I real talk on is sticking with the script. When you go in with agency, you know, in my lecture, you know, see that agency on my second slide, it's there because of the station advocacy conference. In whose name are you speaking? If you're going there as a medical student, you're going there as a representative of the medical establishment. You need to read your talking points and get the solid ones down. There's peripheral stuff. And they go actually trained on this follow. You know, my brother-in-law, right? One of the things to find out about my brother was the left casket. When he come out of the meeting, he would be right down the line with the rest of the trucks. They may argue in the room, but right down the line. Hold that line. If you go and just represent yourself, you need to state that very clearly. This is just my personal opinion, may get the rest of my profession. But be very careful about that because that can erode your basically your viability, your credibility with that stuff.
Dr. Dove, I see being a past president of IOMA, so Dr. Dove, any comments?
I'm just unmuting myself. Can you hear me?
Yep, we can hear you.
Okay. You know, he had mentioned some of our experiences, so I just made a few notes about some of the ways that I've participated over the years. First of all, sometimes you'll find in practice, if there's a new rule or regulations being contemplated either by the state or federal, there's a period of information gathering, and that's where they take input from physicians, and that's a good way, because people do read those comments, and that's important. If they're trying to formulate a new rule that you're for or against. So it's important to submit your thoughts on that. Also, they mentioned earlier during the AOA presentation about sign-on letters. I've done that several times in the past. It could either, again, it could be a state level, it could be federal, or it could even be through your specialty college, where there's a significant matter that comes up and they want, you know, all the doctors' names on it they can get. That's another way that you can participate fairly easily. I've also met with state representative before, our US representatives, and they've come to our healthcare system. And I was medical director of our physical medicine rehabilitation at Unity Point, Cedar Rapids. So sometimes they would come and visit us. And so that was a good opportunity for me they were interested in what we were doing. So, you know, I showed them around, and, you know, if there's any concerns, it's a good way to share that information. Also, if you are going to contact a representative, it's always most effective if you can make it personal. You know, it's a blanket statement. It's better if you can make it personal, like how it affects you as a practicing physician, or how it affects a patient or family. Those things go a lot farther than just looking at you know, how the nuts and screws of how some law might affect someone. So if you can make it personal. But I think most important of all, once you're in practice, we're all busy, and it's always hard to find time to be able to do things in advocacy. So I think the most important thing is maintain your membership in the AOA and also your state organization like IOMA, because that's our eyes and ears. They're out there monitoring these things all the time when you're busy in practice, and they're keeping an eye on things and keeping things honest. And if something does come up, they're the people that can contact you, or you can contact them. So I think that's probably the most important of anything. Maintain your memberships when you get out in practice with AOA and your state osteopathic organization.
Thank you, Dr. Dove. Dr. Meeker, any thoughts or comments you'd like to share with the students?
Yes, I'm on and been listening with interest. I was glad to see some people are going into family practice. Craig and I were intern classmates at Davenport Osteopathic Hospital in the last year that it had that name. And in those years, there was quite a bit of discrimination between even in family practice. We had a rotating internship, and you could do one additional year. And some of the Davenport hospitals where we were weren't allowing people on staff. They had this 3 postgraduate year rule that was kind of really directed at the program. It really affected me and the way I thought. In terms of, I then went to Milwaukee and did a 3-year, second and third year. And then when I came back to Iowa, I was having a really hard time paying off my debts. After about 4 years, I had to leave. And I had probably the ultimate advocacy program as Bill Clinton was running for president. His bus tour came through Strawberry Point, and Al Gore and Tipper Gore and Bill Clinton and Hillary basically spent a half an hour with my partner and I trying to dissect as to why I had to leave. I had to leave because I was buried in debt. And so one of the first things that Bill Clinton did when he became president is the National Service Corps became funded. And I heard you talking earlier about getting loans paid. Now hospitals do it, cities will do it, counties will do it. But the biggest one there is still the National Service Corps. And so I came to Vinton, where I am now, and I wasn't there for very long. And Senator Harkin staffer contacted me and wanted me to testify at a Senate subcommittee hearing and tell this story as to why I actually left an area that was more rural than what I practice in now. And now I've been here about 30 years. I've had a very successful career and enjoy very much a full scope of family medicine. But I've been on the legislative committee for Ioma. I've been to the State House. I don't always participate in the big rollout day, but I do try to speak to our local representatives when I can. Grassley's been to this hospital that I practice several times. And so I always take time to walk through with them. Joni Ertz has been here. A lot of different people have been through. Interested in rural medicine, it's been a hot topic. And just rural life in general is kind of important. It's really hard for towns to attract physicians. So I've enjoyed the discussion tonight.
Thanks for your comments. Dr. Luigi, any thoughts for the students?
Sorry, I couldn't find the unmute button. I want to say that it's encouraging that student physicians take an interest in advocacy. Advocacy is very rewarding if you can win. Unfortunately, you don't always win, and it's a tough battle. But I will say that in my experience, and I've had a lot of experience with the American College of Emergency Physicians, unfortunately, money talks. And when you go up against some of these other powerhouses, meaning interests that are, fighting against you for your cause, there's a lot of money that's paid back and forth to lobbyists and to politicians for legal donations. And what is very important, and unfortunately, I'm kind of preaching to the right group at the wrong time because you have a lot of debt, I'm sure. But what's very important is supporting organized medicine and organized groups for whatever your specialty is with PAC dollars. And doctors don't always want to freely give up their money. And I understand that, because people work very, very hard. But I will tell you that you want to be invited to lunch when there's a politician there to discuss your issue. You don't want to find yourself at lunch and not really being invited and being on the menu. And I can't tell you how many times that's happened to different physician groups trying to fight for causes that were very, very just, but because of other influences, including money, it didn't get them to the table. So best of luck to you all.
Thank you very much. And last, Dr. Menadu, any comments or thoughts? I think you missed it. So, any final questions from anyone? If not, I want to thank everyone for participating tonight. Thanks to Samin and Oscar for helping to organize this activity this evening. So,
Can I make one final comment?
Sure.
Remember, you're doctor, you're not provider. Okay? In the language of the hospital organizations now, everybody comes under the blanket of provider. You're doctor. Okay? There's a difference.
What's the origin of the word providers as applied to physicians? Anyone knows history? Verifiable history, I'll get you the data. Colleges of Emergency Physicians official status, official statement is that you are physicians, you are not providers. You're proud of your degree, you earned it. The history of this relates to World War II. It was first used by Hitler to designate physicians who were not really caring for areas. That's the term providers. Physicians. You don't use the term. When you work with other people who are called providers, honor them also, though, if they're in degree. If someone's a nurse, God bless them. They're a nurse practitioner. How wonderful. If they're a physician assistant, they're a PA, they're a respiratory therapist, they're a physical therapist. Honor them with their degree. That's a such position.
Great. Thanks, everyone, for joining us tonight.
Please feel free to take more stuff.
Yeah, you bet.
Thank you.
Oh, yeah.